Hello and welcome to The Connection, where RLDatix's Chief Customer Officer Liz Jones and Medical Director Darren Kilroy are joined by leaders and colleagues from within the healthcare industry. In The Connection, we explore how people and technology in healthcare can come together to create great experiences and support patient safety. We hope you enjoy listening.
So welcome to this edition of The Connection. I'm Darren Kilroy.
And I'm Liz Jones.
And we thought it would be great just to catch up in this special podcast in terms of where we are in the year. It's the winter and Christmas is upon us, or the new year ahead of us, depending on which way to look at it. And we thought it might be useful just to catch up on where we're at with healthcare, health technology and people as we go through the winter of 24 into 25. It's been a really interesting year for all kinds of political and operational reasons in healthcare, of course. We've had a new Secretary of State, indeed a new government. That brings with it all kinds of exciting new challenges and things to think about. And we thought, didn't we, Liz, it might be an opportunity to just sit down and talk about that for a few months and just get our heads together and think about what that might mean for us in the organisation and our customers as we go into 2025.
Yeah, and it is interesting, isn't it? Because there's always a lot of preparation. I was going to ask you a question.
Yes.
Right. So not too distant past, you would have been... I'm going to take you right back to when you were actually a clinician, in accident and emergency.
Not that long ago.
Well,
yeah, but long enough.
It's all relative.
All relative, yeah.
And I think predominantly in the north of England.
Yep.
Yeah. And you would have been around this time of year. What was it like? Did you have some sort of like sense of dread that you sometimes read about when you read in things like the HSJ, or was it just like normal, life as normal?
No, I mean, it's important. I think the first reflection I'd have on that is that no one in practicing medicine, certainly in my experience, ever read the HSJ. They were too busy looking after patients. And so in that respect but I understand your point, which is, did we or did I pay attention to the narrative around what was happening in healthcare, or were we just too immersed in doing what was required in healthcare?
Yeah.
It's very much the latter for me. Emergency medicine's interesting in as much as if you look at demand and the way that patients flow through the departments, it's busy in the winter for a different reason than it's busy in the summer, but the summer is a busier time because the patients are different, but the throughput is fast. In terms of, you can imagine what I'm going to say, injured kids on trampolines, people having accidents with garden shears, right through to people having car accidents and all the usual things that emergency departments cover. But it's busy in the summer. It's busier in the winter, but more frustrating in the winter because, of course, lots of the patients who come into the department require to be admitted or require some observation for a period of time exceeding the time you've got available in the department because of the nature of what's wrong with them. And that makes it very congested because, of course, as we know, the congestion arises because you cannot get patients moved through the system, for want of a better expression, quickly enough to accommodate the demand on the system. And that creates log jams and bottlenecks and these awful terms that are now thankfully being consigned into history, such as bed blockers. And that is frustrating because in that situation, when it gets cold outside, as it happens to be today as we're talking to you now in Manchester, the patients in front of you have often been treated, been assessed, and been managed in the immediate phase, and you can't move them on. So they're still staring you in the face, which is bad for them, bad for you, and bad for the wider public who are still waiting to get into hospital. So back in my clinical days, this would be a time of year which was busy, just as rewarding as any other time, but the frustrations arose because of the bureaucratic wrangling of getting patients moved through and out of the system into the next part of the system that they needed to be in.
And so how closely, thinking about what is part of the aim with integrated care, and particularly integrated care systems, and then just thinking about what happens in real life, how closely did you work with partners just on a practical sense, picking up the phone, appropriate, or not just you, but people who worked within your department, and did it feel like it was integrated, but through human endeavour versus technology?
Well, in reality, I must caveat this by saying that when I was doing this work on the clinical shop floor, integrated care systems weren't a thing, but the notion was there. This is in the CCG territory. Clinical Commissioning Group was the zenith at this stage. But point being the same is that the work to coordinate between emergency departments, the admissions wards, the base wards, which are the wards that people generally go to for specialist care before they go back to their own home or to their usual residence. The coordination between the internal wranglings of the hospital is hard enough because everyone in their own way is busy. And then to coordinate that with local authorities is even more challenging because, and it's no disrespect to anybody in local authority land because this is just how people work, almost inevitably you need to access those services out of hours, and they aren't easy to access out of hours. because people aren't there in the same way that they are in the NHS. So in reality, it was a frustrating and time-consuming process to organise even the simplest of things. And that's often borne out in busy emergency departments, because when you have a system that is congested, what you tend to find is that people will admit more patients. What's called a propensity to admit goes up, because it's easier logistically to admit people into the system than it is to try and get them home again using local authority resources and other agencies from the front door.
And so this is one of the reasons over a decade ago now, like 14 years ago, that league tables first came into being, right? And not just quality league tables, but really true performance league tables. So we've heard that that's one of the things that the new Secretary of State for Health and Social Care is considering. And as if you put your clinician hat back on, from those days, what's your sort of feeling?
Well, it's tricky, because when you're in a situation where you feel you are being measured and held up publicly to others in relation to how fast you're doing, primarily it's about speed often. And that's a difficult one, because when people are put under pressure of operational speed, they tend, not invariably, they tend to do things that they perhaps wouldn't have done had they not had that pressure upon them. And I remember feeling this very acutely in the early days of A&E targets. And I'm fortunate enough to remember the first phase of A&E targets back in what were the 98% days under a previous health secretary who was happened to be a Labour health secretary, could have been anyone. The pressure, and that was a league table mentality around how fast you could move patients through the 4-hour window. And the aspiration, indeed often the mandate, to have a 98% performance at that rate of seeing patients. You tended to make decisions which were based rather more short-term than you might like them to be around what you were doing clinically in the moment. So league tables in a slightly broader sense then are only ever any good if there is a logic to what's being measured and there is some sense of an incentive to do better, which comes in the shape of either an enhanced workforce, a better resourced workforce model, a better resourced technology to manage the flow, or something real and tangible that will come as a consequence of where you are on the league table. If you just put people in a rank order of a league table for no other reason than just to say where they are, that's pretty meaningless. But that said, I can see the attraction of holding people to account, because, let's be honest, if you're in the NHS at least and working in local authority, you are being paid by the public purse. And there is every expectation, all of us as taxpayers, that every penny that we put into the health and local authority services is being spent wisely. And in that respect there, it's useful and it's to be rewarded to look at how well people are performing in those situations. But as I say, it only works if there is some incentive to do better, which is manifest in terms of support, resource, or some other intervention that makes life easier or better. And that's often not been the case historically, at least.
Yeah, and help me out here. I can't quite get the timeline right, but things like triage, that was introduced as a consequence of some of those targets.
Triage, of course, in its earliest iterations was Napoleonic, and it's a French word which means to sort out. And so triage in its earliest sense wasn't related to targets, it was related to clinical need. Such that if you had a very urgent problem, then there had to be some kind of structure to how the assessments occurred when you first presented to the system. Because even a few decades ago, there was no such structure.
So just on that, so what you're saying is that although there was something happening in the service at the same sort of time, actually one was clinically led and the other one it wasn't a kind of mother of invention type scenario. No, okay,
yeah,
right.
Right.
Okay.
So, but the notion that you would screen people at the first point of contact with the health service, triage is one variation of that, but things have morphed and evolved to a position whereby, driven by the need to perform, for want of a better expression, and to see people efficiently and safely, it makes sense, in theory, it makes sense to, as you or I present to the health service, say it's an emergency department, it could be in primary care, it could be anywhere, that we have a series of objective measures which will determine really quickly what it is actually that you do require from the system. Do you require an emergency department because you've got cardiac difficulties or acute respiratory difficulties or an injury which needs urgent and expert attention? Or is your need psychological? Or is your need actually social? Or is it something else in between? And to cleave away those different pathways as soon as possible makes sense, because then you're not in a rabbit hole of something that doesn't actually benefit you as a patient. And so triage and sort of early screening and assessment at the front door has then evolved to try and accommodate your determination of pathway as quickly as possible so that you have minimal impact on the system. It's awful, but it's true. But you get the outcome you need. And that's why we've seen role evolution in terms of nurse practitioners, specialist nurses, specialist physicians, and others. And I'm only talking here about the front door of the hospital, but it applies just the same in other parts of the system as well, to try and meet that demand in an efficient and cost-effective way without any diminution of safety.
Yeah.
And that's an art and a science because, of course, you have to have a balance between that pathway approach into which stream you will put people into and the resources that you actually need to put in place to service all of those streams properly and consistently, which often isn't as big as you would think. And so that's really what led to this genesis of front door assessments as we now see it. You know, it's trying to manage flow and manage demand while still having an eye on clinical appropriateness and safety so that you hit the right pathway as soon as possible and you're managed as quickly and safely as you can be.
So getting us towards a conclusion on this particular conversation, we always in this podcast go back to the jobs that people do in health and care. And I guess no more so than now as we're heading towards December and there's snow on the ground and all that sort of stuff. What would you be saying to somebody who was thinking, do I really want to be... There's going to be a lot of news headlines, right, over the next 6 to 8 weeks.
Yeah.
Inevitable. Always the same. What would you be saying? What was it like being in it? And what would you be saying to someone if you had a school leaver in front of you now who was thinking,
well,
would I want to be there?
It's always rewarding because when you're in the moment doing the work clinically, or even if you're not clinical, but you're managerial or administrative in the thick of it in the winter, I like to think you always feel you're making a difference. And although it may seem illogical to say this, you're making the most difference when things are at their worst, because even the smallest of actions that you take at that time when you are up against it, and I remember very vividly countless evenings, weekends and night shifts, even as a consultant, of standing in the middle of a sea of patients in an emergency department at 3 o'clock in the morning, of elderly people, babies, working people, people with mental health needs, all in this congested and compressed environment with nurses and doctors and HCAs and therapists and pharmacists even, all working in the small hours to try and sort out these people as quickly and as compassionately as we could. And I remember many times sitting back and thinking, as I watched this in front of me, having sort of an over-helicopter, out-of-body reflection on it, thinking how brilliant it is that all these people, while the majority of the population is sleeping, thinking of Christmas, we're all here in this building at 3 o'clock in the morning trying to sort out all these problems. And how brilliant a career is that, that you're doing that. And yes, it's tiring, and yes, it can be exhausting, and it can be frustrating. But even as I was travelling into the podcast this morning, we've had some awful ice and snow this morning, and it's frustrating and tiring to be in healthcare. It's frustrating and tiring to be driving a bus up a snowy hill that gets stuck. It's frustrating and tiring to be a teacher going to school and being late. It's frustrating to be a school child going to school, and perhaps it's not frustrating, perhaps it's really helpful that you can't get in. But the point being, whatever you're doing, in whatever role you're in, there are frustrations and exhaustion to be had. And we really need to fight against, as this podcast we always try to do, Liz, don't we? We need to fight against the narrative that healthcare is any worse than any other profession in that respect. It's not. And as I say, I go back to that simple principle that being in the middle of all that, in the middle of the night, is a huge privilege.
Yeah.
And those days that are long and tiring pass.
Yeah.
And then happier times arise like any other job. And that's the thing that makes it so attractive.
Yeah. And I guess then the way to follow that up at the end of this is to say thank you to anybody who might be listening to this in the middle of the night over the next few weeks and months, or on the way to work or some such. It's great work, and we're grateful for those that do it.
Yeah. And the end of the shift will surely come, folks. And it's all good. But yeah, thanks for listening. I hope you've enjoyed our podcast today. Take care of yourselves over the winter, and we look forward to speaking to you again soon.
Thank you so much.
Bye now.
Thank you for joining us on today's episode of The Connection. We hope this episode has provided you with valuable insights on the role that both technology and people play within the healthcare landscape. For more information and resources, visit RLDatix.com. Don't forget to subscribe to The Connection on Apple Podcasts, Spotify, or any other podcast platform you use. Join us next time as we continue to explore how healthcare is impacted by connecting people and technology. On behalf of the RLDatix team, thanks for listening.